All right. Well, welcome everyone. We are very pleased to have you all here. Good morning. I'm Katie Schubert. I am President and CEO of the Society for Women's Health Research, which is an organization dedicated to promoting research on biological sex differences in disease and improving women's health through science, policy, and education. We are pleased to have a really wonderful lineup of speakers today. Before we get to that, I want to acknowledge our partners who have been really leading the effort in terms of uterine fibroids advocacy and research. The Fibroid Foundation, the Black Women's Health Imperative, White Dress Project, and the Society of Interventional Radiology. I'd also like to thank our sponsors, AbbVie, Hologic, Myovant, and Roche. We're live tweeting today, so please join us if you are doing so as well and use the hashtag Focus on Fibroids. Now turning into the topic at hand, approximately 26 million Americans between the ages of 15 and 50 have uterine fibroids, and that makes it one of the most common gynecologic conditions nationwide, and also a growing and overlooked public health issue for women. It also affects Black women differently than white women. Black women are at higher risk of more severe symptoms than white women, as well as a host of other issues that we will be hearing about today. We really hope that today's briefing will shed more light on where we are as a country in terms of research and education efforts, as well as the potential policy solutions that we do have available and potentially could help us move this topic forward. I'd like to start today by introducing Mr. Mervyn Jones II, who's a senior advisor at Ancura Consulting. He's also the son of the Honorable Stephanie Tubbs Jones. Mervyn, we so appreciate you being here today to share your story.
Well, thank you, Catherine. I'm sure there's some people who've seen my face before pre-pandemic running around the halls. And I want to say thank you to you, the Fibroid Foundation, and everybody else who was integral in bringing this together. As we know, 80% of Black women develop uterine fibroids during their lifetime. Sadly, many go undiagnosed. 2 to 3 times, Black women are 2 to 3 more times likely to have fibroids and develop them at a younger age. As the son of a mother who battled with fibroids, she lost a child in that with her fight to fibroids, and she would have been my sister, or is my sister, and would have been younger. And this is one of those issues that touched base to me personally, just because this legislation has been relaunched. I was talking to a former staff member of my mother, his name is Patrick Edmond, about this, and this was one of his first bills that he was working on, along with a few other staffers when my mother first came to Congress. And this is why this is so personal. When I posted about this event, people from the woodworks who have worked with my mother on this issue before, Congresswoman Yvette Clarke, those are the people who make this possible. And we're here today to make sure that this issue and this research bill goes further and further so we can ultimately find a cure and a reason for why fibroids affect minority women so savagely. So thank you again, Catherine, for having me here.
Thank you so much. We so appreciate it. And, I think that this is a perspective we don't necessarily always hear so much about, is the impact, not just on the woman herself, but also on her family. And so we're very grateful to have you here, and we'll be bringing you back for our questions, which reminds me that if you have questions, feel free to use the Q&A box. We will be able to see them come in. We'll get to questions at the end. With that, I would like to introduce Sateria Venable, who is a patient advocate and founder of the Fibroid Foundation. Sateria?
For generations, women suffered silently with few treatment options and fertility concerns. Today, 1 in 3 will be diagnosed with fibroids. 80% of women of African descent have fibroids. Our numbers are too great for this story to continue. Will you join me in creating a new story, a movement? Let's let the world know that we are empowered, resilient, and focused. I am Sateria. I was faced with fibroids at 26. Freedom from fibroids will mean that millions of women around the world will no longer suffer. Let's create a global movement together.
Good morning.
Most women.
Good morning. Thank you all for being here today. I'd like to thank Mervyn Jones for sharing his time, his passion about this issue, and his mom's tremendous legacy. I'd like to thank the Society for Women's Health Research and all of our coalition partners and speakers today. I'm Sateria Venable, and it's my absolute pleasure and honor to be with all of you today to speak about an issue that I am so incredibly passionate about. I'd just like to share an overview of our mission. I started this organization focused on fibroids, and I soon learned that the community of menstruators around the world needed support throughout the entire menstrual spectrum, well beyond menstruating also, and in communities where they may be marginalized or have community not have community support when they are experiencing symptoms. So our mission has expanded to support that entire body of people. So oftentimes people wonder what led me here, and it was really this picture. This picture determined the color, the theme of our organization. I was actually at a fibroid retreat in Sedona seeking some holistic support. And I had suffered with heavy menstrual bleeding throughout my entire menstrual experience. Horrible periods at age 11. I was finally diagnosed at fibroids at 26, only because I was so used to coping with the symptoms that I endured them for a very, very long time. And my first surgery, unfortunately, was a really horrible one. I was taken into the surgical suite. I was not prepped correctly. The physician punctured my uterus and they woke me up from surgery and nothing had been accomplished. And so you can imagine what that experience might have been like. And so after that first really upsetting experience, I did not want to have another surgery. There was tremendous fear. And so after the second surgery, which was successful, I launched the Fibroid Foundation. 13 years later, we have a very bonded community of people around the world. And I transformed from a career not related to medicine in any way to try to help prevent having anyone experience what I did. So how do we advocate at the Fibroid Foundation? Well, our main pillar is education, because providing treatment options, saving folks the time and frustration of finding the right providers is critical. We collaborate across the spectrum. We collaborate through with our medical partners, with our holistic partners, with our advocacy partners, and that support and teaming is pivotal. Legislation, as you see here today, we are very passionate about making sure that the advocacy, the legislative funding matches the community. So with 26 million women around the United States suffering with uterine fibroids and millions more in our global community suffering, the research really needs to match the community affected. And when I say community, it's not just the person herself, but the family, work family, and community at large. And then research. We've really found that the patient voice is pivotal in research as well. So here's an example of a research study that Dr. Wallace will also expand on later. But I just would like to point out where we really excel in research is helping to design and provide the patient perspective, which previously has been absent. And one example of that was we vocalized that many fibroids patients who come to their doctor's appointment and are prescribed labs are severely anemic. So getting a lot of labs makes them feel worse when they leave the doctor's office than when they arrive. And so as a result of that feedback, the vial size for the Compare UF, one of the studies, was reduced to the smallest possible vial size. And I consider that such a huge win because it was a beautiful example of patient experience merging with physician expertise. So patient emotions when they're not feeling well is just really difficult to manage. And so I know Ms. Saladino will touch on this later, but there's fear because you've never heard the word fibroid. You may be fatigued from severe anemia, which can be life-threatening. There's embarrassment from soiling clothing, and you may have just struggled through these symptoms. Even if you've had a family history, it may not have been discussed. So we try to help prioritize patients' concerns and encourage shared decision-making with care providers. And that is accomplished with the care provider helping to understand the patient priorities and ranking them and devising a treatment plan specifically around those goals for care. And that's another way that we advocate. And here you see some of the top priorities that our community express, which are pain, trying to avoid hysterectomy, which is proven to have a cardiovascular risk and only be necessary in 18% of cases. Anemia and bleeding, as I mentioned, surgery is a concern, and fertility is a huge concern, as Mervyn Jones emphasized earlier. So collaborative physician-patient relationships have been really critical. We launched the organization with the support of Mayo Clinic and Dr. Elizabeth Stewart, who is just an anchor for us. And in the lower picture, you see one of our community members who sought treatment from 3 physicians and was told 3 times she had to have a hysterectomy. She's in her 20s, and we worked really hard to find a provider in her community who did the surgery that you see there, and that's the fibroid mass that was removed from her body. And so that was a successful collaboration and successful advocacy to help one of our community members to preserve her uterus, to preserve her fertility, and to ultimately meet her goals for treatment. So today we're here to continue the fibroid journey in a positive way by honoring the tremendous legacy of Congresswoman Stephanie Tubbs Jones with the introduction of HR 2007. And Congresswoman Tubbs Jones first introduced this legislation in 2005. And the bill was reintroduced in 2020 and then reintroduced this year due to the change in administration. So we thank her for her tremendous legacy and for setting an example of what we can achieve and how our voices can be heard. And so today we need your support in passing HR 2007. I'd like to thank Congresswoman Yvette Clarke for her tremendous leadership in introducing this bill and the coalition of groups who have bonded with us to make sure that this bill sees successful passage into law. And we really look forward to your support on that, to you reaching out to your legislators, constituents, because we can do this. I'm convinced. And so the bill would be provide funding to the National Institutes of Health and other federal partners for research and education, which we so desperately need because the research to date has not been adequate to avoid the level of hysterectomy and to help us move closer to a cure. The funding would be $150 million over a 5-year period, so $30 million each year beginning in fiscal year 2022. And that may seem like a lot, but when you consider the fact that there are 26 million people in the United States suffering, that's not even $1 per person, hardly. So that's how I really kind of think of it. We need to actually build on that, but this would be an amazing start. And so what will consistent funding accomplish? It will give options. It will provide support. It will provide equity, which is so critical to make sure that everyone has care wherever they are, and knowledge. That's really the basis of all of this. When we know more, we can leverage what we know and accomplish more. Today, the Fibroid Foundation has over 30,000 community members globally in 48 countries. And we look forward to partnering with all of you. Here are just some pictures from our chapters around the country and some of the events that we do. Lastly, I'd like to thank you for your time today, for your attention to this issue, and thank you to our co-host, SWHR. Be well, everyone.
Thank you so much, Sateria. $1 per person. I really like the way that you framed that. I think it makes it very reasonable and a very small investment when you're thinking about that to go a long way. I'd like to now introduce Tanika Gray Valbrun, who is the founder of the White Dress Project. Thanks for joining us, Tanika.
Hi, good morning. Thank you so much, Katie, for having me. Thank you, SWHR. Thank you to all of our partners. And thank you, Sateria, for walking us through HR 2007, the Uterine Fibroid Research and Education Act, really just giving us a transparent look at with fibroids and what your organization has done. Very, very similar to the work of the White Dress Project. And we often do great things together for our community and the sisterhood and really just the country that we have created just to ensure that people are really getting educated about uterine fibroids. Now more than ever, we desperately need policy solutions to address the uterine fibroid epidemic. Every single day, we hear from members of the White Dress Project community that they are suffering. They're dealing with heavy bleeding, the pain that interrupts their daily activities, and all of the other life-altering symptoms of uterine fibroids. Far too many patients aren't getting the answers or the care that they need from their physicians. They're searching for hope in spite of limited options for treatment. And we really want to ensure that we're changing that. We believe that increased research is a critical first step to expanding those treatment options. I started the project in 2014 in of looking for answers of my own. I was in recovery from my first fibroid surgery when I looked in my closet and I realized that I did not own any white clothing. Many with uterine fibroids will identify with this immediately. I didn't own any white because I knew better than to set myself up for an embarrassing stain in public. Since that time, we've heard from people suffering from uterine fibroids around the country. And over again, we're hearing some of the same things, that their doctors just are not taking their condition seriously, that they're not getting the answers they need about their condition, or treatment option presented to them isn't necessarily right for them. Outside of using medication to treat these symptoms, generally people in our community are offered two surgical options, a myomectomy or a hysterectomy. Both are invasive and extensive surgeries, and one takes away the ability to reproduce. People often feel backed into a corner. One of our hopes is that through increased research, which this bill would support, that we can learn more about what causes fibroids, but also newer, less invasive ways to treat them. This type of advancement would be incredible to fibroid sufferers everywhere. I authored an op-ed published last week in Stat, exploring how this condition, uterine fibroids, affects millions of women yet remains overlooked and underfunded among public health issues. In 2019, fibroids received just $17 million in research funding from the National Institutes of Health, putting it in the bottom 50 of almost 300 funded conditions. Even though the direct and indirect medical costs related to fibroids amount to an estimated $35 billion each year in the US alone. It is past time for the response to meet the severity of this public health epidemic and crisis. And one way to do that is through the Stephanie Tubbs Jones Uterine Fibroid Research and Education Act. It's time for Congress to prioritize the healthcare and quality of life for women across the United States. I just want to take this time to thank SWHR, thank our congressional leaders, and all of those who are in support of fibroid advocacy and education and legislation. We applaud you and we thank you for the work.
Thank you so much, Tanika. And I just put the link to that op-ed into the chat box, so hopefully all of the attendees can see it, but we'll be sure to send that out as well. I think really important for us to set the stage and think about where this legislation can bring us, where the needs are. And so I think this is a really good start to our day. I'd like to now introduce our panelists who are going to talk a little bit about the research side of things, as well as sharing their story. And I'm going to introduce all three of you, and then I'll kick it over to Dr. Tingen. But first up, we have Dr. Candace Tingen, who's Program Officer at the Gynecologic Health and Disease Branch at the Eunice Kennedy Shriver National Institute for Child Health and Human Development, or NICHD, for those of you who need extra breaths in there. We also have joining us following Dr. Tingen, Dr. Kedra Wallace, who's Associate Professor at the University of Mississippi Medical Center, Department of Obstetrics and Gynecology. And then she will be followed by Ms. Stephanie Saladino, who's a patient advocate who's going to be sharing her own journey before we get to our questions. So again, just a friendly reminder, pop any questions you all have into the Q&A box, and we will get to them once we hear more about sort of the state of research and where things are going. And with that, I'm going to turn it over to Dr. Tingen.
Okay, thank you. Just share these slides. Great, thank you, Katie. I'm pleased to be here on behalf of NIH to talk to you about some of the science of uterine fibroids and some of the research that we're doing to support this condition. To start, a quick reminder, again, I know that our acronyms are confusing, so a quick reminder that NIH is actually not a giant monolith. It's made up of 27 distinct institutes and centers, each with its own research focus. Some are focused on certain conditions or diseases. Others are disease agnostic, and they focus on research that cuts across conditions. Uterine fibroid research is funded by several institutes of the NIH, including the National Institute of Environmental Health Sciences and the National Institute of Minority Health and Health Disparities. But the largest funder of uterine fibroid research is the institute where I'm located, the Eunice Kennedy Shriver National Institute of Child Health and Human Development, or NICHD. I serve as a program officer for uterine fibroids portfolio at NICHD, and therefore I'm in charge of the Institute's grants to researchers in this area. So for my talk, I'll be walking you through some of the questions that our researchers are striving to answer every day. This question is the starting point for uterine fibroids research. What are they? And we've touched on pieces of this today, but from a scientific point of view, fibroids are non-cancerous tumors that arise from the smooth muscle wall of the uterus. So this is not the endometrium. This is not the layer of the uterus that sheds during menstruation. It's actually a deeper muscular layer of the uterus. As you can see in the image on the right, a single uterus can have many separate fibroids. They can be in different locations and they can be of varying sizes. As we've heard, these tumors are highly prevalent. In their lifetime, most women, upwards of 70 to 80% of women, will get a uterine fibroid. They are the leading cause of hysterectomy, which is really striking when you think about it, because that means that more people have their uterus removed due to these non-cancerous tumors than who have it due to uterine cancer. These conditions cost the United States up to $34 billion every year in healthcare costs and lost work due to symptoms and treatment. As you might imagine from the image here, Fibroids can cause a large range of symptoms, some of which that we've heard about today, including bleeding so severe that it leads to anemia and has large impacts on the quality of life, pelvic pain or incontinence due to the bulk of these tumors as they grow larger, and even, as we've heard, an impact on fertility and pregnancy. Again, that's not surprising if you look at the image and you consider that that largest tumor in the center is really growing within the uterine cavity where a fetus would be growing as well. So who gets fibroids? Fibroids are common in all women, in all ethnicities and races. So the single largest risk factor for fibroids is simply being born with a uterus. However, our researchers and others, as we've heard today, have been able to discover a distinct disparity among those with African ancestry. In our studies, women who self-identify as Black or African American are disproportionately affected by fibroids. They have 2 to 3 times the incidence, have earlier ages at first diagnosis and their first treatment, their first surgery. And they also have more severe disease by the time they first present to a doctor for treatment. So why does this disparity exist? We've heard about the disparity today, but what could be leading to that health disparity? This is a question that really drives many of our studies. And you'll see a tiny selection of our relevant publications to the right here. Our studies have found that there isn't a single easy cause to point to. There's no single gene difference that predisposes Black women with a uterus to higher risk of fibroids. Rather, there are many, many factors that combine to drive the risk higher for the subpopulation. First off, our research has found that Black people tend to be exposed to greater levels of pollutants in the environment and in consumer products that have higher levels of endocrine disrupting chemicals. And that those chemicals and hormonal changes are a risk factor for fibroids. Secondly, vitamin D deficiency may play an important role in development of fibroids, and we know that Black people are more likely to be deficient in vitamin D. Next, the impact of stress is a really, really interesting new avenue of research for our investigators. And their early work is showing a connection between stress hormones like cortisol and fibroids. So the psychosocial influences from racial discrimination that act through these mechanisms of stress may actually be related to fibroid risk at a cellular level. Lastly, we know that there are many layers of potential influence from systemic racism in healthcare and in research. They're amplified by this intersection of race and sex, and that can affect the way that people with fibroids access care, report their symptoms, are counseled by their providers, and make decisions regarding their treatment. So we've talked a little bit about some of the risk factors for fibroids that might be different for Black women or Black people with uteruses, or uteri, like vitamin D deficiency or stress. But what are some of the other risk factors for fibroids, and how do those risk factors really end up driving the disease? Obesity is a risk factor for fibroids, as is earlier exposure to hormones, whether those hormones be from the body itself or from the environment. For example, girls who have their first period younger are at an increased risk for fibroids. Some activities our research has actually found to be protective against fibroids, such as eating a diet rich in fruits, vegetables, and low-fat dairy. From our research, it seems that many of these risk factors are responsible for leading to a chronic inflammation that can then damage the cells of the uterus. When you get that DNA damage and you're unable to repair it because of this inflammation, DNA mutations can occur. Our research has showed that around 75% of fibroids are driven by a mutation in a gene that codes for a protein called MED12. It's an important part of the cell that helps the cell make proteins. When MED12 is mutated, the normal production of proteins is altered and the cell loses the directions that it needs to behave like a healthy uterine cell. Oops. Oh, sorry. So how does this whole sequence of changing a healthy uterine cell to an unhealthy uterine cell and a fibroid cell actually happen? Well, one of the core questions that our researchers work to investigate is, how do fibroids grow and develop? Now, before any of you who hated biology in school go running from the room, please know that you do not have to understand any of the words or the graphics on this slide. This slide is designed only to get across just a tiny sliver of how complicated this question really is and how much of an effort is needed to unravel its complexity. Because for our researchers, the question of how do fibroids grow and develop immediately becomes, What pathways are changed in fibroids? What molecules in a fibroid cell are different than healthy uterine tissue? So for example, I told you that we learned that most fibroids have a mutation in the gene for MED12. Well, the protein MED12 usually fits together with other molecules, and this fit is how it functions. NICHD supported work discovered this structure, which is that blobby structure you see, the picture you see on the left, of how all of these different molecules fit together. They discovered that normal MED12 fits just right in this complex and has to touch each of the other molecules just so in order to activate them. But mutant MED12 doesn't fit the same way. Therefore, this research showed exactly how the mutation in MED12 can affect its function. Now, far more than MED12 goes wrong in a fibroid tumor cell. The full list on the left and many, many other factors are all dysregulated. The DNA gets read differently, proteins change and become active or inactive. All of these pieces fit together in a way that tells the cell to grow and multiply beyond what is normal. One tiny, tiny piece of this puzzle is shown on the picture on the right, which shows just how one of the many effective pathways is involved in fibroids. Now, you don't need to know what any of these parts mean or what they do, but I'd like you to notice all the different pieces involved in that image. Each one of those shapes is a molecule that our investigators had to discover to be important for fibroids. And each arrow between shapes is a molecular interaction that our researchers had to prove. The exciting thing here for us is that once we know these pathways, we can use these pathways to ask which of these pathway components could be targeted for medications, which of them are targets for treatments. For example, if we know that this green squiggle shape is overactive in fibroids, then we can immediately ask, can I block this activity and therefore tell the fibroid cell how to act more like a healthy cell? And that's exactly what our investigators are doing. One team is working to screen thousands of compounds to find which compound could block the activity of that green squiggle, which is known more scientifically as the receptor GPR10, in hopes that the compound would be an effective new treatment for fibroids. This exact quest to find treatments and relief for those who suffer from fibroids is what drives our science. Our investigators are constantly looking for ways to transition the insights that we learn at a molecular level to the clinic where it will directly help those with fibroids. So they ask themselves, can we find treatments for fibroids from vitamins, supplements, repurposed medications that already exist? And amazingly, the answer to this seems to be yes. One of our teams is in clinical trials right now to test whether statins, which you may have heard of as safe, low-cost drugs that are currently used to lower cholesterol, might be effective in treating fibroids. We have another group looking at an extract from green tea, which they've shown can decrease the expression of genes involved in fibroid growth, inflammation, and fibrosis. Another group has shown in preclinical work that the asthma drug Tranilist can normalize levels of some of the molecules that are dysregulated in fibroids. Lastly, of course, the research that we've seen tying vitamin D deficiency to fibroids means that our teams are examining how vitamin D itself could be used to halt growth or even shrink fibroids. Going even further, our research asks, can we develop new medications for fibroids? Because the research has pointed to the importance of estrogen and progesterone as regulators of fibroid growth and symptomatic bleeding, our teams knew that they could be targets to improve these symptoms. Last year, Elagolix, which is marketed as Oren, received FDA approval for the treatment of heavy menstrual bleeding caused by uterine fibroids, becoming the first ever medication approved specifically for that purpose. Unlike hormonal treatments in the past, these drugs are pills instead of shots. They have effects within 24 hours of treatment, and they're associated with fewer side effects, representing a really fantastic new option for people with fibroids. And the whole story of Elagolix started from a grant from NICHD to a small business. A closely related drug, Elagolix, received FDA approval for fibroids last month, which means that we have 2 new treatments for fibroids within the last year. However, the work is far from finished. Even the new medications that I just mentioned affect hormones, and so they can't, for example, be taken if someone wants to become pregnant. They are also helpful in treating the symptomatic bleeding and heavy bleeding from fibroids, but they do not cure fibroids. So our research is still asking, can we give options for fibroid treatment? And as Sateria and Tanika have mentioned earlier, can we give options that are tailored to the needs of the fibroid patient? And can we understand these treatments well enough to help patients decide which of these treatments is best for them? Current treatments include the surgical options that we've heard a bit about, like hysterectomy, where the entire uterus is removed, and myomectomy, where just the fibroid itself is cut out. In the last decade, we've also seen the development of new radiological interventions. Those include uterine artery embolization, where a radiologist delivers small particles to the uterine artery that cause it to shrink, and that cuts off blood flow to the fibroid, which will then cause the fibroid to shrink and die. Magnetic resonance guided focus ultrasound is a long word, but really what it means is using sophisticated imaging to deliver highly concentrated ultrasound directly to the fibroid. You can kind of think of it as using a magnifying glass to concentrate the sunlight and use it to burn a leaf. And then we know much more about each of these treatments thanks to NICHD supported research. For example, our investigators have found that uterine artery embolization provides a higher level of symptom relief and more durability of treatments than the focused ultrasound for women with uterine fibroids. However, embolization treatment had a longer time to return to work and normal activities than the focused ultrasound. So now we know a little bit about the differences in treatment, and we can present those facts and those options to patients when they come in for counseling. Lastly, we've had some medications to offer fibroid patients in the past, including the classics of oral contraceptives and now hormonal IUDs, which our investigators have recently found in a clinical trial to have a high success rate, even when the fibroids disrupt and distort the uterine cavity. However, from the NICHD supported work I've been describing, our previous list of treatments now looks a little bit like this, and we have a nice, an additional list of treatments that could be possible. Including the brand new FDA approved medications, Elagolix and Relegolix, as well as other treatments that our science is currently working towards. As I told you, like statins, perhaps green tea extracts, or maybe something that we're just now beginning to research. Who knows, maybe the green squiggle blocker is the fibroid drug that we've all been working towards. So much progress has been made towards answering each of these questions, but more work is yet to be done. NICHD, NIH, and all the researchers that we support are eager to continue this work on behalf of all those affected by uterine fibroids. Thank you.
Thank you so much, Dr. Tingen. I think you can see there is a lot being done on the research side, and we'll get to some questions toward the end of the session, but I think there's lots of opportunity, it sounds like, particularly in the recent past, so that's very exciting. With that, I would like to ask Dr. Wallace to come on up to the screen and talk to us a little bit about what she's been working on.
Thank you, Katie. So I want to talk to everyone about a large study that we have been a part of. This is the Compare UF study, and Sateria talked a little bit about it earlier. So I just want to give kind of a summary of the study, what we found to date, and really how this study is unique compared to some of the other studies that have been done looking at uterine fibroids. So again, this study was a combination of a lot of investigators spread throughout the United States. So it's not just work of my own, but work from different collaborators. And this was funded by PCORI and AHRQ. So one thing that Sateria and both Tanika mentioned earlier was the fact that the research that we do have, there has not been a lot of patient input to date. So one thing that has been found was that women, when they have conversations with their doctors, they really wanted more input to have more of a shared decision making. So there was a series of studies that was funded by AHRQ and PCORI that had small focus groups that really asked women questions. What is it that you want to know about uterine fibroids regarding your treatment options? What are the questions? Do you want to know about feelings? One thing definitely that Sateria said was a lot of women are anemic. So sometimes when physicians and researchers, when we do studies, one thing that we love to do is we love to take blood we love to see what's going on, especially to look at some of the things that Candace was saying, because we want to see, why do women have uterine fibroids? So one thing that we really need is blood. Well, if a patient is anemic, they may not want to give blood. So really, where Compare UF came in, it was to see, what do patients want versus what do researchers want? And how can we ask the questions and do the studies so that patients can get the answers that they need? So we had a $20 million study, which was spread out over 8 institutions to recruit women. And the entire goal was so that we can understand patterns of symptom relief and how uterine fibroids, whether it was treated with an intervention or medical therapy, how that would help women who wanted to get pregnant, all with the goal of increasing shared decision-making. So one really unique thing was that we had a stakeholder advisory group, and this group was composed of patients as well as advisory groups such as the Uterine Fibroid Foundation. And it also had steering committee, which was composed of all the investigators from the sites. So as you see here in this map, kind of the darker areas, this is where uterine fibroids are really prevalent in the United States. So you see that there's a lot of prevalence here in the southern regions, which for those of you who are familiar with anything of comorbidities such as hypertension, heart disease, diabetes, anything like that, the South has a high prevalence of these disorders. So this is true as well for uterine fibroids. The stars, this is kind of where all the investigators were. So these are our predominant recruiting sites, and the little blue dots, these are just affiliated sites. So kind of the study design. So what we did was really any woman who was having any type of surgery for uterine fibroids, we were interested in her story. So we did not, we had no influence on the type of surgery that a patient would have. What we wanted to do was, if a woman was having a surgery for a uterine fibroid, we wanted to hear her story. So we wanted to know, how do you feel before you have your surgery? How do you feel after you have your surgery? So to do that, we approach women before the surgery. So this is just their intervention, our baseline. And then we also we approach the women 6 to 12 weeks after their surgery, 1 year after the surgery, 2 years after the surgery, and 3 years after the surgery. And then also we had some women who had an intrauterine device. So they didn't necessarily have a surgery, but they may have had an IUD, which has also been shown to help improve some uterine fibroid symptoms. So even if a woman didn't want to have surgery, but she had an IUD to improve their uterine fibroids, we also wanted to hear her story. Some women were hoping to have a surgery to improve their fertility, because as Soteria alluded earlier, and also as we heard from Mervyn, fertility is a huge issue for women having uterine fibroids. So for these women, they had the option of enrolling in a side study to look at fertility. So for those women, we also did a blood draw. So again, one thing that all of our patient advocacy group and our steering committee, one huge issue was, how does uterine fibroids and the uterine fibroid surgery, how does that impact your life? So we had a bunch of questionnaires that we asked women. And again, we asked these women these questions before the surgery and at different steps after their surgeries. One of these was the Uterine Fibroid Symptom and Quality of Life Questionnaire. So with this, we looked at their symptom severity. So with this, the higher the score, the worse this quality of life was. So the worse your symptoms were. This also had a health-related quality of life portion. And this asked them questions on these different domains. And the lower your score, the lower your quality of life. Another questionnaire that we used was the Euro Quality of Life 5-dimension questionnaire. And this had 5 dimensions that we asked women about. And they answered these questions on these different scales. So for instance, if we asked them about mobility, They could say they had no problems with mobility, all the way to they had severe problems with mobility or extreme problems with mobility. And same with pain or discomfort. They may have had no pain all the way to severe pain. And then again, we asked them about their health. So with 100 being that they were in the best health that they can imagine, 0 being in the worst health that they can imagine. And then in addition to this, we also had basic demographic questions. So we wanted to know the race, the age, their zip code, education level. We asked them their relationship, were they single, divorced, and we asked them health questions. So for this study, the health questions, it included questions such as, have you had a uterine fibroid intervention before? Have you been diagnosed with anxiety or depression? Have you been diagnosed with high blood pressure or diabetes? Have you had any type of reproductive problems? We also asked some questions such as, how do you identify yourself gender-wise, or how do you identify yourself with your sexuality? We also asked on reproductive questions. Have you had children? Have you had any miscarriages? If you had children, how long were your pregnancies? So we just really wanted to get the full scope of each patient's history. When the patients, after they had their intervention, we also wanted to know whether or not they had any complications in their recovery. And then if they had to be readmitted to the hospital. So we just really wanted to capture every woman's experience. So what did we see and how did we do? So we were able to recruit a little bit over 3,000 women, and we had a good portion of women in just about all of our major procedures. So as Candace said before, myomectomy and hysterectomy are kind of the largest procedures that are most common procedures that are done. Hysterectomy is complete removal of the uterus. So in Compare UF, we kind of capped this enrollment, meaning that we stopped enrollment at around 30% of that surgery. And one reason is because, again, patients wanted to know about fertility. So we didn't want to enroll women who were all having their uterus removed, because we wouldn't be able to really answer questions about fertility. So we had a lot of women who had myomectomies as well as some of these other procedures. And so one of the very first questions that patients said they wanted to know was, if they had myomectomies, were there any differences? Because there's different routes for myomectomy. Some are very invasive, meaning that some women actually have to have their stomach cut open. Some are less invasive. And so when we looked at that, one of the very first things that we saw was that women who had the more invasive surgery, the abdominal myomectomy, versus the minimally invasive, that their recovery time was longer, about 2 weeks. However, both women were equally happy, as in they had a equally improved quality of life between the two groups. So that's definitely something that we were able to go back, share with all the women who were in the study, as well as when we publish this, share this on our different websites and everything, so that we can just let our patients know, again, to help with that shared decision-making piece. So some of our other studies, we looked at quality of life after myomectomy versus hysterectomy for women who had uterine fibroids. And in these studies, we recruited a little bit over, we included a little bit over 1,000 women. So all women were at least 30 years of age, and they were not trying to become pregnant. And the reason for that is because we were comparing women who had a hysterectomy versus a myomectomy. So therefore, if you were trying to become pregnant, you would not have had a hysterectomy. So we looked at women both at the short-term and at the long-term period. And what we saw was that whether you had a myomectomy or a hysterectomy, both were equally effective at treating both the uterine fibroid symptoms and improving quality of life. However, one thing that we did see as well is that women undergoing a minimally invasive hysterectomy, they actually did better with their quality of life compared to women who had a minimally invasive myomectomy. So whether or not that was due to the fact that women who had hysterectomy now had no uterine fibroid symptoms or not, we were not able to tease those results out, but that is definitely something that we were able to share with our patients, as well as everyone else who even was not on the study through our websites. So we have one study where we've started to just start looking at some of the racial differences, because again, as you've previously heard from Candace, Black women have reported to be more susceptible to uterine fibroids. And one thing that we have shown is that Black women were more likely to schedule a uterine sparing treatment for uterine fibroids. And by uterine sparing, what we mean is that the uterus is still going to stay intact, so we're not going to have a hysterectomy. So we roughly had about 1,100 to 1,200 either white women or Black women that we compared. And what we saw was that Black women tended to be a little bit younger. However, they had more symptoms, uterine fibroid symptoms, and more pain compared to white women. Black women were more likely to have had a prior treatment for uterine fibroid. And then when we compared the results, Black women were less likely to receive a hysterectomy. They were more likely to receive a myomectomy, and they are more likely to receive a uterine artery embolization when compared to white women. So another study that we did is we actually looked at anxiety and depression among women in our study. And what we saw is that when we looked at around 1,500 women, and these women were 30 years or older, and again, these women did not have an interest in pregnancy, and we excluded women who wanted to become pregnant for the reason that if women were trying to become pregnant and they had a uterine fibroid surgery to hopefully increase their chances of becoming pregnant, and they did not achieve that pregnancy, that may affect their anxiety or depression. So for that reason, we excluded them from this analysis. So what we saw is that, and I just do kind of want to remind you here that with your uterine fibroid symptom, the lower your score, the worse your quality of life is. And with your symptom severity, the higher your score, the higher your symptoms. And with your visual analog scale, the lower your score, the worse the patient is saying their overall health is. So what we saw is that women who, this is before their fibroid intervention, said that they were anxious or depressed, they overall had lower quality of life, and they had higher symptom severity, and they said that they were in worse health. So we queried them. So when we looked at the results 1 year after their uterine fibroid intervention, what we saw was that 66.4% of women had an improvement in their anxiety or depression. So what that translates to is that an intervention for uterine fibroids, it improves anxiety and depression. And so being from Mississippi, of course, like I said, I showed you that picture in the very beginning where we saw the predominance or the prevalence of uterine fibroids in the South, and my site was one of the only Southern sites. So one thing that I did once we got our site level data was really to kind of look and see how did women in Mississippi compare to versus our other sites. So what I saw is that when we looked at hysterectomy versus myomectomy, where previously everyone's quality of life improved, that was true among Mississippi women, except as women got older. So in the 35 and older group, that wasn't really true. The quality of life did not improve. And then in this study, where Black women were more likely than white women to schedule uterine sparing treatment, there were 8 sites in the United States that we recruited patients for. This was true in every single site except for Mississippi. In Mississippi, Black women were not more likely to get a uterine sparing treatment compared to white women. And then finally, in this in our most recent study where we looked at anxiety and depression, what we saw was that overall that there was an improvement in anxiety and depression 1 year after uterine fibroid intervention. However, what we saw is just that there were more depressed patients among the Mississippi participants relative to women at other sites. So what I want to leave you with is that the whole goal of research is that we really need to have more research to better understand which fibroid treatment options are more effective and what factors can influence treatment outcomes, with the goal being that we can help women make informed decisions that are best for them and their families to help improve that whole conversations that women have with their physicians to help improve the shared decision-making. Thank you for your time.
Thank you so much. I think that was really wonderful to hear, and also has raised a few questions, which we will get to. I want to introduce Stephanie Saladino to hop on the screen and go ahead and share your story. Stephanie, thank you for joining us today.
Thank you for the panelists for these insights. I've learned a lot today, and for this introduction, Katie. My name is Stephanie Saladino, and I am a patient advocate. I'm here to tell a little bit about my journey with fibroids. And as we've seen today, my story is not uncommon. Many women can share very similar stories with you. And frankly, until this year, this is probably not a story that I'd feel comfortable sharing just because of the stigma surrounding women's health. But the introspection that came with COVID made me think more deeply about how I want to present myself, things I want to change, things I feel very passionate about. So I am honored to be here to share a little bit about my story. And as the other panelists have so eloquently stated, I believe that more awareness of the disease, increased research funding through the Stephanie Tubbs Jones Uterine Fibroid Research and Education Act is necessary to improve care throughout the country. My journey with fibroids started around 10 years ago. I began experiencing heavy periods and severe pain and discomfort. I had gone to my OBGYN several times for ultrasounds, and he always told me that nothing was wrong, the findings were completely normal, and of course I trusted and believed my doctor. This came to a head in 2016 when I was studying for the bar exam to become a lawyer. The doctor had an IUD placed several months prior to that, and I began feeling that something just was not right. I went to the doctor's office believing that potentially the IUD was displaced, which can be a potentially dangerous complication. And once I arrived at the doctor's office, this was met with some speculation and disbelief by my doctor. But we learned that the IUD was in fact displaced, and my doctor pressured me to have another one inserted immediately after. And I did not feel comfortable with that option until I learned, the cause and why this IUD had been displaced. When I arrived home from this appointment, I was scared to find that I was bleeding profusely with large blood clots. I was very concerned about this and told my doctor, who said that he had already seen these clots on the ultrasound and that I was totally fine. It was very troubling to me that he could be so dismissive about such a scary situation. I was also feeling very ill at this point, which made studying for the bar exam very difficult. But I was convinced by my doctor that there was nothing wrong. A couple of months later, the bleeding started back again to the point I could not leave my house. I was also very anemic at this time, very weak and tired. I called the doctor again, and he told me to go to the ER if I was concerned, but I did not think that was sufficient of an answer. And at that point, I decided to make an appointment with a new OBGYN. When I was seen by the new OBGYN, they recommended an ultrasound. After about 1 minute, the ultrasound tech said, "Hey, did you know you have fibroids, like a lot of fibroids?" I told her no, I was not familiar with this condition. My previous doctor had never mentioned it. And my doctor told me that I had a type of fibroid, which likely did cause displacement of the IUD, and it's the type which can typically cause the worst types of symptoms. He actually referred me to a minimally invasive gynecological surgeon, and he said that this was one of the only specialists in the area he knew of that worked on these conditions. So I would have to wait several months before I saw him. So during this time, waiting to see the specialist with anemia, intense bleeding, and pain significantly limited the quality of my life. But I will say I did pass the bar exam. When I finally saw a specialist, I had surgery for removal of that fibroid, but unfortunately the fibroid was not completely removed by the surgery, and I began having symptoms again in 2017. The profuse bleeding caused me again to become very tired and weak with anemia. And this was very difficult to manage when I started working at a firm my first year out of law school. I felt embarrassed to tell my boss about what was happening, and very hesitant to tell coworkers. And I ended up having a very similar surgery again in 2017. Since having fibroids, I am now monitored very regularly for new growth. In August of 2020, I was told that I had a large orange-sized fibroid, and I was diagnosed with endometriosis at this time as well, after many years. I finally saw the specialist in October 2020, and he recommended a more invasive surgery as my best option. I agreed to that, and I was not able to have surgery until January of 2021. During that time between diagnosis and surgery, I dealt with extreme debilitating cramps while waiting patiently for the surgery to occur. I finally had the surgery, which led to 6 weeks of medical leave. And while the surgery was ultimately successful and I'm feeling much better, my surgeon had a significant issue with bedside manner and sensitivity, which made the entire surgery and the situation very traumatic and stressful. I was angry and decided to speak more openly about what happened. And when I started just talking to friends, family, and colleagues about my condition and what had happened, I was just shocked to hear how many women had similar stories about their physicians not taking their condition seriously, not diagnosing them, and then finding some sort of malignancy years later. And this sparked me to want to act and do whatever I could to help women get the care that they need. To this day, I do not have a firm answer regarding how to prevent fibroids, why I have them, and other treatment options, even though the panel was very interesting and illuminating on those points. There is a chance that I'm going to have to monitor this condition for years to come, and I do fear the prospect of more invasive surgeries that will be needed in my future or impacts to my fertility. I firmly believe that earlier diagnosis of this disease would have prevented years of suffering and mismanagement, and it would have allowed me to be more proactive with my health. The way that some practitioners treat women with this disease, which can make us feel like we're diminished and make us feel like we're overreacting, can be very devastating. And I also feel that the lack of specialists that perform minimally invasive surgeries, which can also be very expensive, is a significant problem. Women would also benefit from more treatment options other than hysterectomy or an invasive surgery as a first line of treatment. I feel very fortunate that I did not have to undergo a hysterectomy, but it is possible that a doctor with less experience may have recommended this for me. Overall, women need better treatment, awareness, and research funding for this disease to live full, happy lives. Thank you so much for having me.
Thank you so much, Stephanie. And as Stephanie mentioned, I just thank you for sharing your story. I know that that can be difficult, particularly on this topic. I'd like to invite our speakers to hop back on camera. While they are doing that, I wanted to share a few things that we've gotten some questions about, but also just in thinking about this topic, and we have a few minutes for questions. Number one being the economic burden of fibroids. We know that that fibroids can cost up to $34 billion to the US healthcare system. That women lose 5 hours of work productivity or 3 hours on household productivity per week due to this. So you heard lots of conversation about how do you, have these conversations both with healthcare providers, but also friends, family, and colleagues, employers, et cetera. So I want to get to that question as well. And then there was a question about the current level of funding at the NIH for research in fibroids. And so to put this in perspective, in 2019, the amount of funding that was being put toward uterine fibroids research was $17 million. This is a multi-billion-dollar institute, the National Institutes of Health. And so when you think about the amount of money going into it, and this is me speaking for SWHR, not for the NIH, it puts it at the bottom in the bottom 50 out of 292 conditions. And so when you think about the impact on 51% of the population in this country, that this is common, that people aren't talking about it, and we're learning more every day. I think it's really critical that we think about what we can do to make sure that awareness is raised, but also that breakthroughs can be made as well. So thank you. And I see folks are back on screen. I want to start with a question for maybe Kendra and Candace, thinking about how can you engage the patients and women in research, and what is important for women to know throughout that process.
Dr. Wallace, do you want to start? I think Compare UF is a good example of a success in this area.
Yes. So I think one thing that we really learned from Compare UF is that there's just really vast differences at the region level. I know one thing moving forward for my site in Mississippi is we are really starting to do more at the education level. And then it goes really back to one thing that Sateria was saying, that education is so important. A lot of time, what we really ran into is just that a lot of women, and just are not aware. Mississippi is very, very rural. A lot of women just aren't aware of what's going on, or the fact that they have these very heavy menstrual cycles, and the fact that this is not normal, and that there are options that are available to them other than a hysterectomy. So for us, it's a completely different game about engagement. It is, research is one of the primary mechanisms we have to educate patients and to be able to get in there and to talk to them about, this is a condition, these are some options, let's have a conversation. Because honestly, it's going to take physicians, patients, patient advocacies, research, everybody working together to move forward and help change this whole climate and this dynamics.
Yeah, I think I'll just add, I think there is, medical mistrust and mistrust sometimes of the research enterprise for very good reasons historically, obviously. So sometimes our researchers struggle for recruitment in some populations, and that really harms our research, because we want our research to be applicable to the populations that, that are affected. And so I think that it's our responsibility, on the research side and on the NIH and, clinical side to build that trust back, and to have patient advocates as part of our studies very early on. We've heard Sateria say, it seems small, but just being able to change the amount of blood that we collect was a way that our patients could feel engaged, could feel heard, and that we could look out for, their health as part of our research studies. So I think that's key in starting early in each of our studies.
You. A question that we've seen as a common theme is sort of, how do you, I thought this was normal, I did not know that this wasn't normal. In fact, SWHR had a roundtable last fall, and I had this light bulb moment thinking, oh, my grandmother and my aunt had hysterectomies. I wonder what that was about. And I texted my mom, and turns out it was uterine fibroids. So these conversations are not happening necessarily even among people who, are well-versed in women's health research. And so I think that that's really telling about where we are just in terms of having these conversations. And so I wonder if Sateria and Tanika, Stephanie and Mervyn, if you had advice for folks about sort of how to start talking about this issue, and where can people go, and what should they know to engage in these conversations?
Lady first.
I think that, a lot of times when I speak with people, I invite them to ask the people in their lives. And it's not just the women, but the men I speak with as well often learn that their mother had a hysterectomy due to fibroids, and they had no idea that that had taken place. So I think it really levels the conversation when we invite everyone to look at their immediate sphere of community and relationships, to have that conversation. And usually when people do that, they become more engaged in the community-wide conversation that we need to have as well.
I agree with everything that Syteria said. I can't speak for how women are supposed to address, having or questioning if they do have fibroids. The only thing I'll say to that is, if you have a hunch or a hankering or something that's telling you that something is right, press your doctor. Press them to keep on saying, to find out exactly what it is and find out if it is fibroids. And then I'll address the men in the room, the men who deal with women who have fibroids, who live with them, who eat with them, who talk with them, and pray with them on a daily basis. Be a support. Understand that they're not feeling right. The bleeding and the hemorrhaging, the constant doctor's visits without having the actual solution in sight besides a hysterectomy. Be a support to them and understand and do your research. Know what's going on. Know what you are going to be encountering with your wife or your significant other, and make sure that they are as comfortable as possible, because when it's your turn and you need that kind of support, it'll come back to you 1,000 times fold, because that's what a family is supposed to do. So men, do your research, make sure that you know as much as she does, and go from there.
I love the idea of that. And I'll just piggyback on that, Marvin. Mervin. That it's really important to have a tribe, and it's really important to have a support system. We often talk about encouraging women to bring someone with them to the doctor if you can. It's so important that when you're getting these diagnoses, when you are hearing about new treatment options, when you're trying to decide, it can be extremely overwhelming. A lot of the points that Stephanie brought up just resonated with me so much, because fibroids really takes a whole of the whole woman, right? So it's not only the physical, but the psychological, the social aspect, your career, how you're interacting with people. So really, just the advice I can give is just bring someone with you to the doctor's office so that you can have someone to navigate these very overwhelming waters. And really, it allows you to just feel supported in that moment. Because like I said, when you're getting all of this information poured into you, it can be overwhelming and sometimes hard to make a decision. So if you have a tribe and can bring them to the doctor's office, then do so. The other thing I'll say is that being your own best health advocate is so important, and making sure that you are looking at your doctors as partners. And I always say this is not to challenge any of our physicians and the expertise that they have, their years of medical school and residency, but it's really to know that you are an expert as well on your body, and you know what you're feeling, and no one should dismiss that. You know the pain that you're having, and no one can tell you otherwise. So really viewing your health providers as your personal board of medical directors, I like to call them, and you being the CEO. And together, whatever outcomes you want, we're going to make the best decision for you. So really, I think if patients start to look at their medical providers that way, then we'll start to see a change in the narrative on physician-patient interaction.
I saw a question come in, and I need to wrap this up, so I apologize, everyone. This is, I think, been such a wonderful conversation, and really, I think, shows the need to continue this conversation. There was a question that came in about healthcare providers, and so I wanted to just say that part of what the legislation that we have been talking about, HR 2007, does have in it is a provision for the development and dissemination of fibroids information to healthcare providers. So that's one piece of the puzzle too, that I think is really important in thinking about okay, how can we as patients come in and have this conversation, but also on the other end, what information are healthcare providers armed with? And I think to Stephanie's point, you know, if she had seen a different provider, the answer maybe would have been different, and that conversation would have looked very different. And so I think for all of us, you know, this is something that we need to continue to keep in mind during Uterine Fibroids Month, and to see, you know, this issue coming up, you know, and continue to be talked about. I want to thank you all again for joining us. I want to thank our partners, the Fibroid Foundation, the White Dress Project, Black Women's Health Imperative, and the Society of Interventional Radiology. I also want to again thank our sponsors, AbbVie, Hologic, Myovant, and Roche. We would not be able to do this important work without their support, and this partnership that we have. So I have to encourage everyone here to support HR 2007. I need to thank Congresswoman Clark for her championship and picking this up from Congresswoman Stephanie Tubbs Jones, and really to be able to carry that legacy forward, and really move this issue forward. You know, she wrote an op-ed back in 2007 about this topic and the need to move it forward. And so we are at this point where it's really important for us to be doing that. We will be sharing the recording of this event, as well as links to resources and one-pagers. But for right now, just please reach out to your members of Congress, encourage them to co-sponsor the legislation. We'll be seeing that Senate bill coming soon. We'll share more about that as well. And again, thank you to our wonderful speakers for coming today, sharing your stories, your thoughts, and wisdom with our audience. So thank you so much, and everyone have a great day.